Hello and welcome. My name is Jane Houston and I'm the Clinical Director of Midwifery and Women's Health at Frontier Nursing University. I'm very happy to introduce my colleague, Dr. Erin Tenney, who lives in Washburn, Wisconsin. Dr. Tenney has been a certified nurse midwife and women's health nurse practitioner since 2010. She recently completed her advanced practice nurse prescriber certification in 2017 through the state of Wisconsin. She received her master's degree in nursing and midwifery, her postmaster's certificate in women's health, and her doctoral degree in nursing from Frontier Nursing University. She's also a certified birth doula and trainer through DONA International. Her clinical experience has been in tribal healthcare on reservation lands in northern Wisconsin, with a focus on community health, traditional birth practices, and supporting the Indigenous midwifery movement. She's currently regional clinical faculty at Frontier Nursing University for students in Wisconsin, Minnesota, and Illinois. I'm delighted to introduce to you Dr. Erin Tenney. Thank you.
Hi everyone, this is Dr. Erin Tenney. I am a regional clinical faculty member at Frontier Nursing University, and I'm so glad to welcome you to Nurse-Midwives Answering the Call, where we're honoring and highlighting the many facets of the beautiful and ancient profession of midwifery. I'm going to share some of what has called me to midwifery and what I'm inspired by every day in my work and the direction I feel we need to be moving. I hope you'll be encouraged and inspired to answer the call as well. So I want to start with an introduction and acknowledging the ancestors of the place where I now live and call home, right on Lake Superior in northern Wisconsin. So this is a picture of myself, and if you look at the map here, the light tan shape is Wisconsin, and I live at the very, very, very northern tip where the tan meets the blue, and there you can almost see some light tan speckles. Those are the Apostle Islands, and that's where I live. I want to acknowledge the many people who've taught me so much and helped bring me to this place where I can present for you, including my family, my friends, my colleagues, and my most recent and significant teachers, Mishkawa Naba'amakwaban from the Red Cliff Band of Lake Superior, Chippewa, and Wabanukwe, Doreen Day, a traditional midwife from the Boyd Fords Reservation in northern Minnesota. My recent ancestors have lived in this area for between 100 and 400 years. They emigrated from Western Europe and Scandinavia. During the French fur trade, one of the French men in my family line married an Odawa woman. Hopefully the circumstances were loving and ethical, although I can't be sure, from Wisconsin. So the roots of my family are firmly planted in this area. For the past 15 years, I've worked in health clinics on reservations in Wisconsin. For most of that time, I served the Red Cliff Band of Lake Superior, Chippewa, and now more recently, the 4th County Potawatomi community. These tribes actually share a history as part of the Anishinaabeg or Anishinaabe original peoples who started out on the Atlantic coast about 1,000 years ago. They migrated west along the Great Lakes according to the prophecy of the 7 fires. In the 1500s, this group split into 3, the Ojibwe, or the keepers of the faith, the Odawa, the keepers of the trade, and the Potawatomi, the keepers of the fire. These 3 tribal groups make up what's known as the 3 Fires Confederacy. These tribes were located around the Western Great Lakes and had a huge land mass, but as a result of a series of forced treaties, primarily in the 19th century, their vast lands were ceded to the US government, and they became restricted to very small, distinct land bases called reservations. And this map here shows the reservations in Wisconsin. And you can see they're quite small areas. And the 2 areas I want to point out are the northernmost square here. There are squares with symbols, and then they point to the landmass. That the yellow one with the black shapes, that is the Red Cliff Band of Lake Superior, Chippewa. And then if you look on the eastern or right side of the map, you can see the northernmost symbol on the east side of the state. Looks like a medicine wheel with 3 feathers is what they are on the bottom. That's pointing to the 4th County Potawatomi tribal reservation. And I do travel between those 2, which is a 3-hour commute one way. I have been honored to work with and for these communities over the years, and I've learned a lot and often think about the healthcare and the role of culture in these settings. I also reflect on my role within this and how to be a respectful practitioner. I look forward to highlighting some of the unique aspects of tribal healthcare, which really differs from the mainstream in significant ways, and which a lot of people might not be aware of. So I'm really excited to share some of what I've learned about that. So I do want to just share a little bit more about my background and where I've been up until now. So my research interest is in qualitative research. For my doctoral presentation, I did some interviews and international literature review and looking at the supports and barriers for midwifery care, specifically in Indigenous communities. So all over the world, but focusing on it in the US. I'm really interested in working on a community level to support Indigenous midwifery and traditional birth practices. And I think you'll learn more about why that would be, with the ultimate goal really to decrease the health inequities within specifically the Native population in the US. There's not as much research with this population. A lot of the information we have is based on very small numbers, but we know that there are certainly disparate health outcomes, especially for mothers, children, and families. So that's where we're working. And I do want to offer just a quick lesson on vocabulary and history because that gives some of the context to this presentation. So the word Indigenous means the descendants of the original inhabitants of a place before those of other ethnicities arrived. So in the US, we would say the American Indian and Alaskan Native people to refer to the original people that were here before the European migration began. And I'll also use in different places the words tribal and they use native or the word native. And these in the area where I work, these are the common terms that are used in referencing American Indian, Alaskan Native people. It definitely differs depending on where you are. And I just want to say that in the circles that I travel and the areas where I am, these are considered sort of the common terms and respectful. So those are ones I use, but certainly want to acknowledge that other areas might use different terms. The other thing we need to keep in mind is that in the US, there's incredible variation in tribal cultures. There are 562 federally recognized Indian tribes, bands, nations, pueblos, rancherias, and communities and native villages in the United States. And almost half of these are actually located in Alaska, and the rest are in 33 of the other southern continental states. The tribes vary incredibly in terms of their ethnicity, culture, and their languages. So we do need to keep in mind the context of this time in history. We are post-colonial in terms of thinking about our Indigenous communities here, meaning that we in this country, colonization was the process whereby immigrants came and essentially took over the native lands, and there was a very deliberate forced cultural genocide of the Indigenous people here. So that is the context for this time in history. That cultural genocide was widespread. It was deep and quite violent in many occasions. And it did result in significant multi-generational trauma, which the very resilient Indigenous people living today still experience the effects of that and are working to overcome that. So my focus is really on the positive, recognizing that we have a very dark history and we're trying to move on from that place while not forgetting or denying, but really taking that into account and moving forward and celebrating the revitalization of language, culture, ceremony, and health, which is really happening in many Indigenous communities and is really strong and healthy and beautiful. So we know that culture and prioritizing culture and celebrating culture is where healing comes from, and therefore cultural safety in healthcare specifically is really key. So keep all of that in mind as we move forward, and thank you for hearing that long introduction. I hope that was helpful. So the learning goals for this presentation is learning about what cultural safety is, and then learning about some of the unique aspects of tribal health care in terms of culture, community, and caring, which really reflect culturally safe care. So when we talk about cultural safety, this is a specific term that is different than other terms referring to culture. And it is a theory that was specifically created to address nursing education and by extension, nursing practice in a post-colonial society in New Zealand. So it was developed by a woman, Irpeti Ramsden. She is a Maori nurse in New Zealand. It was developed in the 1980s, and it really upholds the political ideals of self-determination and decolonization for the Maori people in New Zealand. So while it was developed in New Zealand for the specific group of an Indigenous people, I feel the theory and concept is relevant when we're discussing other post-colonial societies where Indigenous people have been disenfranchised and then experience this health inequity as a result. So I believe it can be translated, and other researchers have shown that we can translate it to similar communities that have experienced a somewhat similar history in Canada and Australia and in the US as well. So I am making that leap, but I do feel that it's appropriate. And it's important to note that this theory was developed by an Indigenous health professional. She came from a non-dominant society in New Zealand. And so her perspective that she brings to this theory, I believe, is very significant. In the US, here, some of the other cultural terms that we've heard and used in nursing education, we often look at the to the transcultural nursing theory. And this was developed by a white researcher in Canada who presumably came from a more dominant Western society there. So that perspective is key. And what cultural safety does is it recognizes the power imbalances between the nurse and the patient based on socio-political and historical contexts, where the nurse or provider is not from that Indigenous community, but is serving someone from that community. Culturally safe care is dynamic, and it's determined by the person receiving care. And culturally unsafe care, as a contrast, includes any actions that would diminish, demean, or disempower the cultural identity and well-being of an individual. So this particular term is actually not commonly used in the US. We don't see it a lot in the literature or the research. And some researchers have critiqued it for being somewhat non-generalizable or non-transferable to cultures where we have many ethnicities and cultures, such as in the US. But I do feel that it is specific and very relevant when we're specifically talking about Indigenous communities in a post-colonial society, such as here in the US. I'm going to share a few more tenets of cultural safety, which I think illustrate the concept and the importance of it and how relevant it is today. So cultural safety really focuses on teaching students about the colonial history and its impact on the Indigenous peoples, rather than on increasing knowledge about Indigenous customs and health beliefs. So if you think about the concepts of cultural competency or cultural relevance, those are some that we might hear more here. Those historically have been focused on teaching a generalized set of criteria that might explain a certain community, such as American Indians and Alaskan Natives, and asking the student to learn that set of criteria and apply it to that population. It was a start, but I do feel like this is where we need to be moving in terms of our approach to cultural care, where we don't generalize a population, but where we really learn about the people in terms of history and sociopolitical concept. And then leading into this next key, also focusing on self-discovery on the part of the student and by extension healthcare practitioner, who need to learn to evaluate what they are bringing to the table in terms of their own invisible baggage in the form of attitudes, metaphors, beliefs, and values. So asking the individuals to really do some critical self-reflection, as well as self-reflection on the society in which they live, and recognizing that what the provider brings is really a key part of that interaction in a healthcare setting and needs to be conscious and come from a respectful and self-aware place if that care is going to be culturally safe. It aims to identify the attitudes that many consciously or unconsciously may hold toward cultural and social differences in healthcare. Again, this is working on uncovering the unconscious bias on the part of the student or healthcare provider, and really working towards then transforming these attitudes by tracing them to their origins and seeing the effects on practice through reflection, and then carrying that through to action. So we talk a lot about root cause analysis, and this is really speaking to that before it was a common and popular term. So really looking at the roots and being authentic and self-reflective in our approach. So let's look at how tribal healthcare is taking some of these concepts and these tenets and actualizing culturally safe care today in many ways. So tribal healthcare is special in that it really is for the people. So let's start again with context and remember that prior to colonization, Indigenous societies were complete. They had unique, holistic, and complex systems of care, and they had extensive knowledge of plant and animal medicines. These were carried and passed down through healers and medicine people over the generations, have been developed over eons, worked well, and often these medicine carriers were the midwives in community, which of course is relevant to our talk. So keeping in mind that this system was already in place, and then following that through to the history of colonization, then we move into the era of Indian health services. So this is a health service that was created by the federal government in the US in 1955 to address the atrocious health conditions, which were largely created by the policies of relocation and cultural genocide, including boarding schools and many other conditions that led to extremely poor health conditions. So in the 1950s, the US government recognized these conditions and did create a health service specifically to serve the Alaskan Native and American Indian people. And it's important to, so while it was good that this health service was developed and continues today, like other arenas of healthcare in the US, over the past century, there were dark pockets of history in the early days of Indian health services. And one example of this is the forced sterilization of Native women in Indian health service clinics. And this was happening up until the 1970s, so into my lifetime, not that long ago. So there naturally remains a distrust on the part of some Native people of the healthcare system, and this is warranted. And it really calls us to give even greater attention to cultural safety as a way to help recover from and heal from those atrocities and move into a much more safe and equitable type of healthcare. So Indian Health Services does continue today. It provides funding to tribal communities to provide healthcare for their communities. It is grossly underfunded. They fund less money per individual than any other governmental health care service, such as Medicaid or Veterans Assistant. And it is in danger of greater funding cuts in the current political climate. So it is a tentative and not adequate funding source, but it is there, and it does provide services to tribal members. Often the clinics funded by Indian Health Services are on reservations, but not always. They can be in urban settings as well. And there are different models or designations for tribal health clinics. They can be just purely funded through those funds. They can be tribally owned or some combination of those two. And this varies greatly depending on the wealth of individual tribes, and there's a great spectrum of that. And some are also designated as federally qualified health centers because they may be in rural areas, and they may serve non-Native people as well if they have that designation. So keeping in mind there's variation in how these clinics are funded and who they serve and how they function, as well as the settings. But what tends to be common and special about these tribal health programs is that they really are for the people that they serve. They are not typically for-profit clinics, as we see in what is becoming mainstream medicine, is very much profit-based. And these are not. They are specifically designed for and focusing on serving American Indian, Alaskan Native persons. So the care can be more focused culturally. And we see that in some of these tenets that I'm going to explain here. And we really see this manifest as well in the unique involvement and participation of the community. The way the care really does focus on culture in many ways and the particular types of caring that we see. So I'm going to outline each of those three areas, but first we're going to talk a little bit about midwifery in this setting. We have to talk about midwifery, of course. This is about midwifery, and there's really a beautiful type of care and a really beautiful, strong movement happening around midwifery in tribal health care. So as I mentioned before, and it's important to keep in mind, the traditional midwives in these Native communities often were the medicine keepers and the healers. They were very well respected and really important members of the community. Unfortunately, many of those practices may have been lost, but certainly not all. There are a handful of Indigenous midwives still practicing, and a lot of that sacred knowledge was protected and was kept and passed on through the generations, and the sacred knowledge is carried and starting to be shared again. There's a really powerful revitalization movement happening among Indigenous communities, and these midwifery, birth, parenting, and women's health practices are being shared again and taught to younger midwives. And they are starting to be slowly but surely privileged in Indigenous communities so that the birth practices can be and are being revitalized. And I'm going to just share a story. This little baby, Shailene here, who is pictured, she is an Anishinaabe baby from the Red Cliff Band of Lake Superior Chippewa tribe, and she was born last year, and she was born at home. Her mother was studying traditional midwifery with Wabadukwe in a group of us, and she decided to have a traditional home birth because she was learning about the songs and the ceremonies and the practices surrounding how birth would have been done. And she chose to create this birth setting for herself and her family, and had a beautiful birth that included all of these aspects. It was very beautiful for the family. They talk about it with much pride, and she said I could share the story. And we're seeing this happen in our area and in other tribal communities where this is really coming back into the mix, and it is absolutely beautiful and absolutely the source of much healing. And this movement, some people call it the decolonizing birth movement, where these practices are being reclaimed, and the practices that were imposed on colonization are being rejected, or at least relegated to where they belong as perhaps part of the care package, but not necessarily dominant or the only option. So a lot of exciting healing is happening here, and I really work hard to support this movement and want to see it continue, and it will, because it's powerful. So when we talk about tribal healthcare, midwifery included, but also in general, One of the beautiful, unique aspects is the community involvement really takes place at every level. So tribes have tribal councils, which are recognized by the federal government as local tribal government, and by definition, they are on the same level as federal government and state governments, and should be respected as such. And they oversee all of the actions of the tribe in general. There's also a health board at tribal health clinics, which are also made up of community members who provide guidance to the clinic-specific activities and services. And then on both of those councils, and perhaps in addition, either formally or informally, we often see elder involvement, as the elders are respected for their great wisdom, and their opinions and guidance are often used to help decide even concrete things like which services will be offered. And one example I have of that is at the Red Cliff Health Center, when we were deciding whether or not to offer centering pregnancy as one of our midwifery services. We invited one of our respected elders from the community to come and meet with the administrators and myself as the nurse midwife, and Sharon Rising, who's a woman who designed centering healthcare services. And we all sat down together at a picnic table outside on a summer day and talked about centering and whether or not it would be a good fit for the community. And as a result of that conversation, the elder gave us guidance and the administration agreed that it would be a good fit. And so they put me in charge of starting it at the health center, and it worked really well. Another way we see that community is integrated into the healthcare we provide in tribal communities is that we see community health services integrated into primary care and being under the same roof as the regular medical clinic. And we see community health representatives working in community health and alongside the healthcare providers to deliver really excellent care. And community health representatives do not have medical training. They're community members who are hired by the clinic and often work out of the community health department to be the front line and liaison between community members and the healthcare providers and services being delivered. And this works extremely well because they are community members. They know everybody, they know what's happening, they understand the culture, and they are a vital link between helping people get to their appointments, helping providers understand what's really happening with families and provide appropriate care. And we see that community health and medical care are truly integrated in a way that in mainstream care, these services are often siloed and not nearly as effective. We also see that community events are abundant in many tribal communities, and healthcare providers are often heavily involved. And this is one of my favorite things about tribal health. In fact, tonight I am going to the New Baby Welcome community event in Red Cliff, where the community comes together to celebrate all of the babies born in the last year. So we're looking forward to a community feast and gifts for all the babies. And some of the women that have had traditional births in the last year are going to share their stories with community. And myself as a health provider, as well as other health providers in the community, will be there as well, because we're all part of that care for these families. It's a really wonderful thing, and these events happen often. In the picture above, this is a picture that I took from the Red Cliff Powwow last year. And you can see that all the shawls the women dancers are wearing are pink. And this was in support of breast cancer awareness and in support of some of the survivors and those who have not survived breast cancer within the community. So I also gathered with these women. We had several sewing sessions. We all brought our sewing machines and pink fabric and pink ribbons, and we had a blast, and we sewed shawls in preparation for the powwow, and then the women danced in honor. So that's yet another example. Another important example is how some of the cultural uses of traditional medicines are still honored, and this is a really vital part of medicine even today. So I'll explain this sign because you probably have not seen this in your clinic. This is a sign from the Forest County Potawatomi Tribal Clinic where I work, and you can see it says spiritual tobacco use only, and this is in place of the typical no smoking sign which you often see in public places. So in Indigenous communities, tribal communities, at least in the region where I live and the tribes that I've worked with, tobacco is a very sacred medicine. So the tobacco leaf, the tobacco plant, is considered one of the 4 medicines, along with sage and sweetgrass and cedar, and it is often used in prayer. So it might be used in a prayer pipe, it might be held in the hands when one is praying, and it can be offered to people when asking for something as a respectful way to ask or receive. And so it's very spiritual. And so the message is different within tribal settings. We don't just say, don't smoke or tobacco is bad, as is the more common discourse. It's recognizing that spiritual tobacco use is healing, whereas the more recent commercial use of tobacco in the form of cigarettes is harmful and can be deadly. So those are differentiated so that the spiritual use of tobacco can still be honored. And this is another way that is expressed. This is also at the Forest County Tribal Health Center. And this little stand here is located in the pharmacy. So we have our typical pharmacy, but then we also have this place where people can take loose leaf tobacco. That's what that bag is. They can take it in their hands, and that little sign says, if you want to give thanks, if you want to say a prayer and hold this in your hand, go ahead and take this tobacco and put it in the bowl, and then someone will be responsible for taking it out at the end of the day and putting it back on the earth. So this is how we see that still used. And sometimes we'll have prayer ties of tobacco that are actually in a small bowl in the exam room, so patient can take these if that feels good to them. I know I've had those in my exam rooms, and they disappear. Patients appreciate, I think, having that option. And sometimes we put cedar over the doorways, which is another way that we create a protective setting for these healthcare encounters. We really see that the culture is honored and reflected in the physical environment in tribal clinics, especially where they have the means to invest a little extra and make them beautiful. So we see a lot of natural products and setting being used, a lot of stone and wood and round areas. There's a beautiful sculpture of a man sitting, tending a fire, a Native man tending a fire when you walk into the lobby of the health clinic where I work, and that's because those people are the fire keepers, as I mentioned before. So lots of important symbols. We also see photos of community members on the walls, which is really special. And we just really see that throughout the lobby, and that helps create a safe environment. We also just really, in general, in tribal settings, we tend to see a holistic view of health being honored. And this can be manifested in sometimes the meetings that take place in these settings, especially if they're important. They might start with a smudge, which is a burning of sage or other medicine plants, and that just helps clear the area and prepare the space for positive interactions. And sometimes these events or meetings are also, will start with a blessing, often in the Native language and offered by an elder. We do at times refer to traditional healers and might suggest ceremony for our patients, knowing that that might be part of their healing circle and what they believe in and what will work for them. And at one of the clinics I work with, there is a formal way to make that referral, and at the other, it's more just informal and knowing who they might want to talk to. There is a medicinal plant garden at each of these clinics where they grow sweetgrass and sage so that patients can go and pick those if they need them. And sometimes we'll see sweat lodges that are actually set up or perhaps referred to. And I've seen these a lot, especially in alcohol and other drug treatment programs. So a lot of those cultural practices being honored and used even today. So it's really important that we recognize these things, and we see that still today, many of the healthcare providers in these settings are non-Native people, and they may not be aware of these practices or these medicines or these teachings. And it's really important that we do recognize these cultural elements and these approaches to health so that we can integrate them into the care, be more appreciative, and then really respectful in how we deliver that care. And just a little bit more on caring. Any healthcare setting is based on caring. That concept is not unique or special, but the way it's expressed, I think, can be in tribal clinics. The care is very intimate, and especially when you're working in rural communities where it might even be a smaller population, people know each other. The web of relation is tight and wide and deep, and a provider might be caring for generations of people in a family. I know I had one really special encounter where I actually was caring for 3 generations of a family that I had known over the years for a long time. So I had helped the grandmother with some menopause concerns. The mother is someone that I had been with in several of her pregnancies. And then I was actually at their home doing a breastfeeding support visit for that new little baby, actually the one that was pictured. And it just struck me how special that is when we have intergenerational relationships and care. And that also allows us to provide really personalized and thorough care because we know more about that individual because we understand a little better their family and their community. And there are also some really wonderful structural things that I have seen take place in tribal clinics. One is that appointment times are longer. So, for instance, my appointment times are either 40 or 60 minutes for a return visit or an annual exam or something more complex. And as we know in healthcare, that is pretty much unheard of. The typical visit time for a physician is 12 minutes, I believe, and for a nurse practitioner, it's closer to 20 for a routine visit, maybe as much as 40. But this is a conscious effort to ensure that patients receive personalized, high quality care and that providers have the time to really get to the problem at hand and provide holistic care. So as a provider, I cherish my time with patients. I love that we can and do go deep in a visit, and often we'll get to many areas, and often we can get to deeper underlying issues that may be really the root of some of the more surface health issues that are being manifested. So that's really key. And there's also an awareness of, in these settings, of the unique stressors that some of the community members might be experiencing in terms of accessing healthcare or being healthy. And there's really a proactive approach to meeting the needs. So this often looks like comprehensive transportation programs to make sure that community members can get to their visits, and sometimes they even extend to making sure they can get to the grocery store or to Walmart to get their needs for the month. And depending on the needs of the community, that looks different, but recognizing and not taking for granted that transportation is not always available and can be a barrier to care. We also see a lot of services for elderly people. And one of the reserves I work with, there is no nursing home, and often there's not. And so there's a great attention to be sure that there are meal programs for elderly people, often delivered to homes, that there's a lot of community events, transportation, and other home care focus on making sure there's okay. And we also see community gardens addressing the food desert issues that often exist on reservation areas, food pantries, and just a really holistic approach to making sure that basic needs are met. And then a few individual examples of how we see caring really manifested. I've seen staff routinely go above and beyond to deliver medicines after hours to client homes. There's a lot of clinic employee fundraisers to help specific families with particular hardships. And we see, we'd get together and make cupcakes and decorate and have bake sales and raise, $700 to $800 for a family whose baby was in a distant special care unit. That's just an example. And because of the relationships that form in these intimate settings, this feels very personal and it happens a lot. Another really caring example I have is that a nurse practitioner at one of our tribal clinics was in, a position of needing to give a tribal member a diagnosis of cancer. And she knew this tribal member. He was an elder, very traditional man, and he did not feel comfortable in the clinic setting. He didn't routinely come for care because he felt a distrust of the system and just didn't trust it. So this nurse practitioner is very sensitive, and she knew that about this man and really respected him. And so she did arrange to meet him at a nearby outdoor setting as this beautiful campground right on Lake Superior that was just across the street from the clinic. And she arranged to meet him over her lunch hour so that she could give him this diagnosis in a beautiful outdoor setting as opposed to what she knew would be a very uncomfortable clinic exam room setting. I just thought that was really beautiful. And another example that I want to offer of how all of these different individual, structural, community, caring, culture, all of this comes together. This actually happened to me yesterday in clinic, and I thought it would be a great way to share how we see this happen. So I was asked to meet with a prenatal client. She is 28 weeks along, getting care from a different doctor in the community, not myself. But one of the community health nurses had been contacted by this client's mother, who was very concerned about her. And so this community health nurse tracked her down. She called multiple times, and then she took one of the tribal vans and went and picked her and her boyfriend and child up and brought them to the clinic. We added her to my schedule, and we all met together to talk to her about how she was doing. One of her main concerns was dehydration because she was feeling nauseous and had diarrhea. I'm pretty sure it was just sort of a viral GI bug. But what was really manifesting was her anxiety. And as we sat down and spoke, and we had about an hour to meet together, it became really apparent that her anxiety was the main concern for her. It was becoming really overwhelming and starting to haunt some of the smaller things in her pregnancy care and her ability to care for herself. So she had recently been ill. She had also recently been diagnosed with a cervicitis and needed to take antibiotic treatment. But her anxiety was preventing her from taking the antibiotics because she was scared they were going to hurt her or make her more sick. She was just really scared about multiple things. Scared of needles if she became dehydrated and had to go to the hospital, scared of who would care for her or who wouldn't. And so as we were talking, we got to talk about her anxiety. And I asked if anything recent had happened. And she paused and said, well, actually, it's been worse in the last few months. And when we dug down, it turns out she had had a really terrifying experience with an ex-boyfriend and was suffering trauma from that experience and had really, she was suffering some panic attacks and anxiety. And it turns out she was in a situation where she was forced to continue to see the person where with whom this trauma occurred, and he was very threatening, and this was ongoing. And so because we were able to get to this depth, the community health nurse, who she trusted because she had known and her sisters knew and her brother knew, she was able to make some referrals to a mental health counselor as well as an advocate who could help with some of these ongoing situations that were triggering her panic. And at the same time, I was able to reinforce that the antibiotic treatment was safe and she needed to take it, and that she could remain hydrated if she was able to focus on fluids and, bring her boyfriend in helping make sure that happened. And fortunately, she was feeling better from the viral illness. So when she left, she was able to meet with the advocate before even leaving the clinic. She was able to pick up all of her medications. Her child was cared for during the visit, so that was not a stress. And she had transportation home when she was done. And all of this happened in a fairly integrated fashion. So I'd like to use that as an example of how it works and how care can and does happen in tribal settings. So to conclude, I just want to offer some takeaways that I want to highlight, and just really want to say we have so much to learn and appreciate about our tribal health systems and the Indigenous approach to healing. I think tribal clinics and tribal communities are very misunderstood. I think there's some really damaging generalizations and misunderstandings that continue. And I think we often disparage Indian health clinics for the weaknesses, but that's really, I'd say, pales in comparison to the strengths, and really the way that a lot of tribal healthcare systems actually lead the way in culturally safe care and taking a more traditional caring approach. And I think we have really so much to learn and should hold these up in a lot of ways as model programs and take heed of the lessons that we can learn. We really see that community is at the center, and the patient care actually is patient-centered. So in this context, I think it's not just a marketing angle. I think it's really happening, and that is special. And of course, there is still much work to be done. So I like to take an optimistic approach. We also can't be complacent. We need to keep working. And these are some areas to work. We know that tribal communities are so resourceful, but of course there are still really significant limitations to how the healthcare is provided because it is still limited by and filtered through a Western medicine healthcare system. So there continues to be sort of an imposition of a cultural system of healthcare that is not necessarily a good fit in Native communities, and that in itself is a limitation. And of course, there continue to be significant funding and resource shortages. So we need to work on that and hopefully improve that situation. And then really this call to be more self-aware on the part of the student and the practitioner in terms of what we bring to the interaction. This is really key, and I think it's rarely acknowledged and rarely acted on. I think we're still very largely ignorant of these power and privilege dynamics in healthcare. And if we are non-Native, if we are white, if we're working within Native communities and then women and families of color, we really need to understand white privilege. We need to recognize that we're working in a system that upholds these privileges, and it impacts all of us, either positively or negatively. And even though we don't like it and it's not okay, it doesn't mean we can ignore it anymore. We need to continue to live and work in this socially unjust system, and we need to work hard to make it more just. We know that our system is contributing to health inequities, and we know that we need to fix that. We need to turn that around. And I believe that working towards a socially just system is really key to answering the call in our profession of nurse midwifery. We need to move the profession forward, and we need to be able to truly deliver equitable and culturally safe care. So I hope you're leaving with a greater appreciation of what culturally safe care is, of what healthcare can and does look like in some of the Native communities in the US, and how we can participate in that, appreciate it, and help advance this care to just improve society, improve healthcare, and make it a better place, because that's what the call is all about, and that's what we're here for. So I want to say miigwech, and thank you for your time and attention. I want to say miigwech to all of those who have come before us and the many who are working so hard today on all of these issues. So we do this for our families, we do it for the children that are coming, and for whom we want a better world. So again, miigwech, thank you, and please feel free to contact me if you want to continue the conversation. My email is erin.tenney@frontier.edu, and that will be on a slide at the end. And thank you again. Miigwech. Have a great day.